amphetamines, Ritalin, and Ritalin. So any stimulants are going to provide, again, the same sort of pattern, but the tolerance to intoxication is profound, right? Interestingly, when you're treating ADHD, the patients stop feeling the buzz of the stimulant very quickly, but they still are having much less symptoms of PTSD. Was that a correct sentence? I hope so. Right, ADHD is painful, isn't it? But they are getting better, yet they still don't feel the buzz from the amphetamines. So that's an interesting, patient that can take that, Concerta, Ritalin, Adderall, whatever you want, day after day, and they don't feel it, yet it's still working. But the stimulant addict, the stimulant abuser, they need more and more and more and more, and they're not getting anything out of it. And taking it away is, everything in the world is the worst ever. So when they've overdosed or intoxicated on it, for the most part, it's supportive care. If they get enough on board, they can get paranoid. They can get, frankly, psychotic. And you may need to treat that with a dopamine antagonist. Right? That's the big part of amphetamines. They are pushing dopamine out into the system. So a dopamine antagonist may affect this directly. So you can solve that problem in the emergency room. But for the most part, again, the care is supportive and it goes away quickly. Overdoses could potentially result in cardiac problems, strokes, seizures. So definitely emergency room stuff. Quick bit on cocaine with alcohol. It binds to form the evil cocaethylene, which is more potent and more toxic and will hurt you. And look at that. We don't have anything about what to do about that. There isn't much to do about that, except if you're talking to someone who uses coke, say try not to drink with it because of cocaethylene. And you shouldn't do that. What do you use for stimulant use disorder? Look at all those question marks. Right, and who's been, and I don't mean personally, experiencing bath salts? So bath salts is a pretty powerful stimulant. What I've read on Erowid.com, Erowid, EROWID.com, like MySpace for drug users, it is awesome, by the way, if you're trying to get some information like from the ground level. These amateur chemists are brilliant. If drug users, but brilliant. And they even talk about bath salts. It's not even fun, yet they can't stop doing it. It's like got all the compulsion without the reward. And no one that I know has really found a good medication treatment regimen that's particularly useful for cravings when someone's trying to stop using their stimulants. Modafinil, maybe. Wellbutrin, maybe, but honestly, most folks, they find if they work, they don't work really well. There's no study that really is that encouraging. So withdrawal, again, it's supportive. They're anhedonic, they're anergic because they're without their stimulants. And really, it's going to be all psychosocial care once you see what you're looking at and you know that it's stimulant withdrawal. So psychosocial treatment, CBT, behavior therapy, 12-step is about all you got. So stimulant abuse and addiction is a really tough one. Marijuana, here in California, is not a disorder, right? And I'm only half kidding when I say that, because for someone to believe they have a disorder, it has to be screwing up their life. So that is an important consideration. If you're in a situation where someone is able to get marijuana, they're able to afford as much as they want, they're never in trouble because they're getting it, and they don't feel that it's hurting their life, the fact that you think it's hurting their life is immaterial. That you're not going to get very far in your motivational, interviewing technique. I've tried it before with stoners. It's not fun. But the addiction, and it is possible to be addicted, right? Marijuana takes so long to leach out of the fat cells, or it's fat soluble, so it's all up there in your brain, and it's leaching itself out, that people don't necessarily have the profound withdrawals, so they don't think that they're addicted, because they don't necessarily find that they're in a world of hurt, after they've been without it for a day. But the fact is, they do have kind of subtle withdrawal symptoms, and they do show signs of dependence. So screening and management, while intoxication, it's all in the snail. It's right there. When you got the snails in your head, all right, someone is intoxicated with marijuana. Screws with their time sense. The one I don't see on the list is believing you're funny even though you're not. Right? It's probably all you really need. High doses, people can get downright paranoid. Psychosis can happen, and there's some interesting, scary studies about certain people who are vulnerable can become actually persistently psychotic. That's a different thing than probably a different thing. I wouldn't want to stand my feet too hard on that, but they can have psychosis just from intoxication. And then long-term heavy use is the famous amotivational syndrome, low attention span, no insight, like they had insight when they started, depersonalization, introversion, loners, not communicating well, etc. So marijuana withdrawal, it's, we're cranky. Let's wipe all that out and say cranky. And people are losing weight. They don't really feel like eating because they don't have the munchies anymore. So they're dropping weight and feeling bad. And it's very subtle. So they may not see it as marijuana withdrawal. They may come to you and say, I'm depressed. And they don't realize they're depressed because of their marijuana deficiency. So again, psychosocial treatment is all you got. You ready for some despair? Look at that. Nothing. That is the treatment for marijuana deficiency. Nothing. I don't know that anyone has found anything yet that really adequately treats a marijuana use disorder. But again, the really hard part is getting someone to admit they have a disorder to begin with. So, far be it for me to end on a hopeless note, but marijuana is a tough one. Oh, they're not letting me end on a hopeless note. There we go. So psychosocial treatment for marijuana use disorder, again, motivational enhancement therapy, good luck. It's called amotivational syndrome for a reason. So we're trying to provide some motivation. Again, using motivational enhancement therapy and motivational interviewing in someone with marijuana use disorder is desperately trying to help them understand that, yes, it's hurting your life more than you think. And then behavior therapy, and that's about all you got. So in summary, we'll try to be a little more hopeful. A substance use disorder can be conceptualized as a progression from an impulsive to a compulsive disorder. All right, impulsive, I'm doing it because I feel like it. Compulsive, I'm doing it because I have to. This progression is linked to alterations in not only dopamine and the reward circuit, right? It's changing the reward circuit that it's hijacking. It's almost as if it's a big conspiracy theory. But some other neurotransmitters and circuits are involved. We didn't talk about them too much today, but they're all there. Many of these drugs are causing some pretty global deficits in all the various systems in your brain. The management of substance use disorders differ slightly by substance, but it generally involves both psychosocial and psychopharmacological treatment. And the substances with evidence-based pharmacological treatments are alcohol, opioids, and nicotine, which we didn't really cover very much for the purposes of this discussion. And with that, let's go back to the questions.